We'll continue with Dr. Vogl with the question, when is conventional imaging enough?
So thank you very much for the invitation to give a talk on this not easy topic, I would say, and not very, let's say, a sexy topic in front of nuclear medicine physicians. And the only disclosure adding on to this is that I'm a medical oncologist and not an imaging specialist, so have mercy with me. So I'd like to start from the basics. So what is the definition of conventional imaging? So conventional imaging in prostate cancer is the imaging that is or has been conventionally and traditionally used. So CT, bone scan, and MRI. And molecular imaging or modern imaging, sometimes called in prostate cancer, is PSMA PET. In some indications, FDG PET, and I think historically choline PET. And we know that for many years, PSMA PET has arrived in the station. And we all know, at least since APCCC 22, that the train has left the station. So just the first slide again that Daria already presented for localized prostate cancer. The recommendation is quite clear, and I underlined in red, if available, PSMA PET-CT to increase accuracy. And it's all clear that the preferred staging here is PSMA PET-CT, especially in high risk and locally advanced. But we know that the lack of widespread availability and also the lack of reimbursement for many patients, that they are still staged with conventional imaging. This is a map on the right that I found of the output of academic works and publication on Diagnostics worldwide. It might also reflect the accessibility and availability of patients receiving imaging, modern imaging, and also treatment, nuclear medicine treatment. And this, of course, reflects only a small proportion of the world where PSMA PET-CT has really been introduced into daily clinical practice. Just to show you also this survey done in 22, actually on the indication of when should we do PSMA PET imaging. And here the priority has been given to primary staging and biochemical recurrence, whereas for monitoring responses systemic treatment, it is not yet ready for prime time. And we'll hear more on that tomorrow in the presentations. I'd like to kick off a little bit localized disease with an oncological dilemma we sometimes have at our tumor boards weekly, actually. And this is the indication to add on abiraterone to radiotherapy and long-term ADT according to the STAMPEDE trial. And you know, that STAMPEDE actually enrolled in the years between 2011 2016, where we were far away from PSMA PET-CT using as baseline staging. So everything was based on conventional imaging, and especially I want to highlight this, the clinically CN1 disease that Daria already showed some pictures, that actually the definition in STAMPEDE was for conventional imaging, so large lymph nodes, so more advanced disease. So in 2025, most STAMPEDE-like patients receive PSMA PET-CT imaging for their baseline staging. So we confronted in a patient that would be a candidate for curative radiotherapy with the outcome of CN positive disease on PSMA PET-CT, but CN 0 on conventional. And this makes us difficult decision-making if we should add on abiraterone. Being very conventional, let's say, of course, the criteria for STAMPEDE are not fulfilled if the diameter of the lymph node is not actually in conventional imaging present. And this is a case that my nuclear medicine physician shared with me that we discussed only last week on our tumor board with a patient that had a lymph node diameter actually discussed from the radiologist as being non-suspicious, but being positive on PSMA PET, and otherwise the patient didn't have other criteria to fulfill the STAMPEDE high-risk criteria. And again, already in the first presentation, as Professor Galina mentioned, also the clinical staging, let's say, the clinical digital rectal exam also lacks its accuracy to define. And this patient, for example, was on MRI and also on PET deemed to be more a CT3. So we have those borderline cases where we say CN1 on PET, but not on conventional, but we have other risk factors that might declare these patients an optimal candidate to intensify actually treatment. So this is one of the dilemmas. So should we discuss with those patients abiraterone when we have CN1 disease only on PET? In my personal opinion, we have the learning curve of the nuclear medicine specialists at our board or everywhere in the world has grown in the last years, and I think we should trust and see what they say about the likelihood of certainty of those CN positive disease. And personally at our center, patients are counseled, but knowing very well that these data are based on conventional imaging. So let's go back to last year. What did the panelists say on this dilemma question? So PSMA PET only lymph node positivity, but otherwise no other criteria for adding on abiraterone, according to Stampede, and actually 71% would offer the patient abiraterone in this CN1 PET only situation. The other dilemma, let's say, that we know very well is that we stage the patient with PSMA PET CT instead of conventional imaging and find already de novo metastatic disease, which is mostly oligometastatic, whereas in conventional imaging, there are no metastases. So what was the trust, what we see voting of the panelists last year, especially the recurring question of bone lesions actually without a correlate on the CT component? I think this is, again, something that we just discuss daily at our boards. And let's say last year, but it might change after APCCC Diagnostics, 75% of the panelists didn't trust PSMA PET only positive lesion, but would request something to add on like conventional imaging or biopsy. Let's see how it develops in the future. I think what we've learned and has been also stated in various reviews that the 18F PSMA 1007 is less preferable than the gallium PSMA, that we know that the RIP positivity can make us some troubles. And I think what should be standard is that we use also the CT contrast when we perform a PSMA PET CT. So the question, conventional imaging in metastatic prostate cancer at first diagnosis would be done in a few minutes, in my opinion, because if we, again, are very conservative on that, all pivotal trials of approved standard of care treatments used exclusively conventional imaging. Though, of course, again, many patients are already staged with PSMA PET CT nowadays. This is a very busy slide just to summarize what trials have been done. First, in non-metastatic and metastatic castration-resistant prostate cancer, of course, historically earlier. And you see here in yellow really homogeneously imaging methods, CT, MRI, or bone scan. And actually, this is the same for metastatic hormone-sensitive prostate cancer trials, going from docetaxel to ARPs, and also in the triplet trials. What was interesting, and of course wanted to highlight, which is another question for daily clinical practice, is the interval of imaging. You see that the academic trials were more open, less rigid in when to restage an MHSPC, whereas the industrial-led trials were more rigid on the restaging. So this is another unanswered question, the interval of imaging. But not to close the eyes of development and introducing PSMA PET imaging in our daily clinical practice, I just wanted to highlight two trials actually from the work that we're doing for the another manuscript for the lack of consensus from APCCC 2024. These are two trials that actually include as primary endpoint a PET correlated endpoint. So in PET advanced disease, so the Thunder trial and the ARASTEP, Thunder is in high-risk prostate cancer, but with PSMA PET CT positive non-localized disease, also including Decipher. And here the primary endpoint is the PPMFS, so PSMA PET metastasis-free survival. I think we have to learn that. And ARASTEP actually includes also patients that have PSMA PET only positive lesions, so distant metastasis on PET with an rPFS by PSMA PET CT. So the estimated completion date is not so far away, actually. And with the permission of Professor James, actually, I also wanted to highlight that Stampede 2.0, a large trial done in metastatic hormone-sensitive prostate cancer now, also will include in the new protocol version PET scan to be one of the tools to determine the SABR eligibility and ineligibility will be, which will be part of this Stampede 2.0 trial. Monitoring will be discussed tomorrow. in metastatic disease, but again here underlining conventional imaging, the prostate cancer work group criteria, which we use also for reassessment of disease outside of clinical trials, are based on CT, MRI, and bone scan. But also here, work in progress. PSMA PET-CT is coming up, also for prostate cancer working group 4. There will be a talk tomorrow, including PET also in this strategy. So to summarize, when is conventional imaging enough? We've heard not in localized disease. So if PSMA PET-CT is available in intermediate, unfavorable, high-risk or locally advanced prostate cancer, it is the first choice, including preferably CT with contrast. It's still enough to stage patients in metastatic disease with conventional imaging for baseline and monitoring, although, of course, real world is different. I think that the regular use of PSMA PET-CT will presumably lead to earlier treatment switch and maybe also more work for the radiotherapist, introducing more SBRT, especially in early progression. If this has impact on OS is still to be awaited from larger prospective trials. And I'm really happy that also modern imaging will be implemented and give us a guidance in the future with PSMA PET-CT. But I'm the oncologist and I have to deal with the reports and the images and critical interpretation of imaging, baseline results and reassessment, especially for progression, independent of what imaging we use, conventional or modern, should be critically evaluated together with PSA and also with clinics. But keep calm and trust your nuclear medicine physician, because the learning curve is excellent, and without them at our board, decision-making for our patients wouldn't be that great. Thank you very much.